As a patient healthcare advocate, I appear in front of you today with concerns over the lack of improvement in childhood obesity rates. The time is now that we work together to end the childhood obesity epidemic. I'm requesting that today you listen to the statistics I present on childhood obesity, effective programs that have been implemented to combat this epidemic, and how health policy at all levels of government can be used to improve this healthcare problem that will have a devastating impact on the health of future generations if we do not work together to implement strategies to combat and prevent childhood obesity. Childhood obesity is a major crisis within the United States as it puts children at risk for poor health. This is the first time in our history that a generation of American children may face a shorter than expected lifespan than their parents. A BMI at or above the 85th percentile and below the 95th percentile indicates a child is overweight, and a BMI at or above the 95th percentile indicates a child is obese. Childhood obesity is a complex health issue caused by factors such as a child's behavior, genetics, living in a community that does not support healthy habits, such as providing affordable, healthy food options and policies geared towards promoting a healthy lifestyle. Obesity strikes at an early age, with a shocking 9.4% of children 2 to 5 classified as obese, and the obesity rate for children ages 6 to 11 has more than quadrupled during the past 40 years. Overweight or obese children are at higher risk of developing health issues such as asthma, heart disease, cancer, high blood pressure, type 2 diabetes, joint and bone problems, and sleep apnea. These children are also at higher risk from suffering from low self-esteem, anxiety, and depression when compared with children of a healthy weight. Obese children have 3 times more health care expenditures compared to healthy children, costing an estimated $14 billion yearly in the United States. Obese children are 10 times more likely to become obese adults, which impacts the United States medical costs. Medical costs in the U.S. related to adult obesity is estimated between $147 billion and $210 billion annually. Recent estimates suggest that if obesity trends continue their path, annual medical costs linked to obesity could rise by 48 to 66 billion per year by 2030. According to the Centers of Disease Control and Prevention, there has been a steady rise in children aged 2 to 19 battling obesity from 1999 to 2016. The Commonwealth Fund's scorecard on state health system performance added childhood obesity as part of the Healthy Lives Indicator in 2011, which assessed data from 2007 to 2009. Using the scorecard, 32% of children 10 to 17 were overweight or obese in the United States, with rates ranging from 24% to 39% among the top and bottom states. As seen in this chart, most children who were overweight were Black or Hispanic, lived below poverty level, and were uninsured. Unfortunately, the Commonwealth Fund scorecard of state health system performance for 2014 revealed that there were 19 states with no change in children who were overweight or obese, 18 states with improvement in obesity rates, and 14 states with higher rates of obesity when compared to the previous scorecard. When looking at the U.S. average rate of obesity in children 10 to 17, there were 32 in 2009 and 31 in 2014, revealing an insignificant change in obesity rates. Although the scorecard in 2014 revealed that a significant majority of measures were stagnant or declining, it also revealed that combined national and state action has the potential to promote performance gains across the country. There are many efforts made to combat the complex issue of childhood obesity within the United States. SNAP WIC Child and Adult Care Food Program, menu labeling, dietary guidelines, nutritional facts labeling, physical education and physical activity in schools, food marketing to children, and healthy food financing initiative are all ways the United States has put into effect policies to help promote healthy eating and decrease obesity within the United States. In 2016, Head Start performance standards took effect and required programs to actively engage in obesity prevention in the classroom and through family partnerships. These standards required healthy snacks, culturally appropriate nutritional services, easily accessible drinking water, and the integration of physical activity into the daily curriculum. These new standards have had effective results as children who received 60 minutes of outdoor play time during Head Start programs were 42% less likely to become obese at the end of the school year compared to children who played outside less often. Research has also showed that children participating in Head Start programs are 3 times more likely to have healthy eating habits compared to other low-income children who do not participate in this program. Another way Head Start was successful was that preschool-aged children who entered Head Start at an unhealthy weight had a lower BMI by kindergarten compared to children who were not registered in the program. The majority of children consume up to half of their daily calories at school, and more than 29 million children participate in the National School Lunch Program. Schools are a source of affordable, healthy meals for children from low-income families, as 51% of U.S. children qualify for free or reduced-price school meals. The Healthy Hunger-Free Kids Act of 2010 is the most recent iteration of the Child Nutrition Act and has updated nutrition standards for school meal programs to reflect the latest nutritional science and increase the federal reimbursement schools receive for serving meals meeting those standards. These standards were put into effect in 2012 and require more whole grains, fruits and vegetables, fat-free and low-fat milk, less sodium-saturated fats, and added sugars. Those buying school lunches are now choosing more fruits and vegetables as part of their meal, leading to 28.2 million students participating in school lunch to have a healthier diet, better academic performance, and reduced health risks such as obesity. According to Harvard researchers, over the next 10 years, these healthier standards will prevent over 2 million cases of childhood obesity and save up to $792 million in healthcare costs. Fighting childhood obesity is a complex battle with some efforts less effective than others. Taxes have helped to reduce public health impact on alcohol and tobacco. Taxes on sugary beverages have come into effect in some states, but it is too soon to tell if this tax will lower obesity rates, as the soda taxes may be too low to affect purchasing behavior, and people may switch to other unhealthy foods or buy soda in neighboring cities that do not tax them. Another issue is chronic conditions like obesity and diabetes take years to develop, so it may be years before benefits from these taxes are seen. Another issue is that the beverage industry strongly opposes these taxes, and in 2016 it spent $30 million in California to oppose new ballot measures to impose beverages taxes in Oakland and San Francisco, both of which have passed. Industry-funded ads expose the taxes as a tax on consumers' freedom, an unfair burden to low-income families, and bad for employment and the economy. Lastly, the powerful soda industry has effectively lobbied for state laws banning new local beverage taxes, making added difficulty to furthering the movement to tax sugary drinks to lower the rates of obesity. Let's Move was a public health campaign led by Michelle Obama that aimed to reduce childhood obesity and encourage a healthy lifestyle in children by creating a healthy start for children, empowering parents, providing healthy school food, improving access to healthy and affordable foods, and increasing physical activity. Although the campaign motivated children, critics believe that it focused too much attention toward reducing sugary food and not enough on limiting cheese, meat, and grain consumption. Critics also point out that the rate of childhood obesity has not gone down since the start of the campaign, with the rate of obesity remaining relatively unaffected over the past decade. Those who support the campaign believe it will be years before the true effects are known. Measurement has become a major area of focus in the United States healthcare quality improvement efforts, with various initiatives requiring healthcare providers to collect and report on performance measures to help drive healthcare quality while reducing costs and improving patient experience. As obesity is on the rise as well as its associated costs, there is a need to address this burden on our healthcare system. Using quality measurement within obesity will provide valuable insights into disease management and will contribute to the systemic effort of improving treatment and prevention. Measure endorsement through the National Quality Forum is the gold standard for health care quality and performance measurement. HEDIS and the National Quality Forum quality measures call for screening children 3 to 17 for BMI percentile and improving weight management among children as well as adults by counseling on nutrition and physical activity. HEDIS assesses children's BMI percentile as BMI norms in youth vary with age and gender and is better measure than absolute BMI. A lower BMI percentile, an increased proportion of children meeting current federal activity guidelines for aerobic physical activity, an increase in legislative policies for environments that enhance access of physical activity opportunities, an increase in the proportion of children living in safe and supportive neighborhoods, reducing the mean calories consumed among children, adopting policies that prohibit the sale of sugary drinks and prohibit these drinks in schools, reducing consumption of calories from solid fats and added sugars while increasing the consumption of fruits, vegetables, and whole grains are all examples of quality indicators that will be used to measure the positive outcomes made in the battle on childhood obesity. Prevalence of childhood obesity continues to remain high within the United States, especially among racial and ethnic minorities and low-income populations. Obesity is a complex, multifaceted issue with no one simple solution. As there are a complex web of influences associated with obesity, many have called for the need of broad population-based strategies for preventing childhood obesity, but increasingly the public health community has been advocating for a systems-based approach to obesity prevention that recognizes the policy, environmental, and individual level factors that affect behavior and outcomes. The Institute of Medicine recommends that action must be taken within the 5 environments of physical activity, food and beverage, marketing and messaging, healthcare and work sites, and schools, as well as within all sectors of the government for obesity prevention to be successful. Childhood obesity interventions should be supported by policies at all levels of government, national, regional, and local. National policies can produce supportive environments. Regional policies can facilitate pooling of resources, and local tailoring of intervention results in more effective targeted interventions. Evidence reveals that the most successful interventions are adapted to the local context and are culturally and environmentally appropriate. A policy option that could promote healthy weight in children is to continue enforcing and extending legislation that restricts the availability of unhealthy food and drink in schools, improves the nutritional quality of foods and beverages sold at schools, and increases the accessibility of drinking water in schools. Other policy options include funding and facilitating high-quality programs in schools that meet existing nutritional and physical activity standards, expanding opportunities for daily exercise outside of physical education, integrating food literacy education into lesson planning, ensuring that anti-obesity efforts effectively address racial and ethnic and social economic inequalities, encouraging shared use agreements to make school recreational facilities available outside of school hours in neighborhoods lacking safe places for physical activity, implementing common standards for marketing food and beverages to children, promoting evidence-based practices to promote breastfeeding initiation and duration, supporting public education to promote healthy eating and active living, especially in those populations vulnerable to obesity, and support and plan for communities that encourage walking, bicycling, and outdoor play. The future of our children is of utmost importance, and necessary action is needed to lower childhood obesity rates to create a healthier tomorrow. Provided are my references.